I would now like to introduce Sherri Zelazny. Sherri Zelazny is a clinical speech-language pathologist with advanced clinical expertise in voice evaluation and treatment. She has a long history of involvement with the Parkinson's community as a clinician providing Silverman Voice Treatment for Parkinson's for more than 20 years. She has been an honorary member of Wisconsin chapter of the American Parkinson Disease Association since 2011. She joined the PSBC Board of Directors in November 2012. Sherri also contributed significant time and energy to piloting the Society's Communication and Swallow program in 2014 and continues to present this program. She is past president of Speech and Hearing BC. I'd like to pass it over to Sherri Zelazny now. Sherri, welcome and thank you for being here today.
Okay. Thank you very much. Oh, I've got some kind of an echo, but we'll try to manage that today. Thanks, everybody. Very happy to see a good crowd today. We will go through some information on communication and swallowing disorders with Parkinson's, and like Alana said, I will try very hard to answer all your questions. You're welcome to put them in the chat box, and we will likely have some time at the end, and if I don't get to all your questions, I will do so after the fact today and get the answers to you, but hopefully we'll get to everything today. So Alana did tell you a little bit about me, but I'll just give you another little rundown of where I've come from. I'm born and bred in the Northeast of the United States in Massachusetts. Did my undergraduate at Ithaca College in Ithaca, New York. I did my master's degree at NYU. I spent the first 15 years of my career as a speech-language pathologist, as a general speech-language pathologist in Laconia, New Hampshire. I did a little bit of everything during that time: inpatient, outpatient, home visits, schools, you name it. I did it in those first 15 years. In 2002, I was fortunate enough to go to the University of Wisconsin-Madison to specialize in voice and voice evaluation, diagnosis, treatment, and stayed there for about 9.5 years. And then in 2011, we moved to Surrey, which is where I still am, and very, very happy to be able to continue my specialty in voice and be involved, of course, with Parkinson Society BC. These disclosures, most of them have been identified, but I am a member of the Parkinson Society BC, something I'm very proud of on the board of directors, and humbled for sure. I received no compensation for the preparation or delivery of this workshop webinar today. I am a registered speech-language pathologist with a private practice in Surrey, and I'm past president of Speech and Hearing BC. I wanted to start with just letting you know about the revision to the Canadian guidelines for Parkinson's disease that came out in 2019. So important for everybody to understand that rehab therapists experienced with Parkinson's disease are so important in, an important member as part of your team. We have for many years argued, advocated that rehab should be involved from the very beginning with the new diagnosis of Parkinson's, because we know there are so many exercises and treatments and approaches that help along the way and help slow the progression of the disease. And of course, through all stages of Parkinson's, we think it's important to have a rehab team. The other, well, like I said, we really want to emphasize early involvement with rehab specialists, PTOT and speech, especially, I of course will argue for speech-language pathologists related to communication and swallowing, but early on in the diagnosis and in your care and in your approach to quality of life, There are so many things that we can do to help you and to stay in a good place with communication, to keep swallowing safe, and we want to help get that message out to the medical community. I have said several times in the workshops, the full day workshops that we've done, I've had experience over the years with people who say their physicians wouldn't refer them for speech pathology because they weren't bad enough yet. And that it's just heartbreaking. We are not only there when things get bad. We want to prevent things from getting bad. And education today, the education that we hope we're providing today, is part of maintaining and improving quality of life, for sure. My role as a speech language pathologist in any speech path is to, of course, evaluate and treat communication and swallowing disorders, but also, help with education and prevention, counseling and support to you and your family members regarding communication and swallowing disorders. So let's just look at why we talk about communication and swallowing together. And basically, the short answer is it's all the same parts of your head and neck that contribute to your ability to communicate and swallow. From the brain down, their brain generates ideas, communication, and most importantly, movement. Your respiratory system is your breath support, the power, the energy for your voice and articulation. Phonation is the word we refer to for voice or vocal fold vibration, your sound source. Your articulators are your mouth, lips, teeth, tongue, palate, cheeks, everything in your mouth that produces speech, and in addition allows you to chew and swallow safely. And then the resonant cavities of your head, your nose, your mouth, your sinuses, all of those spaces play a role for voice. The easiest example I guess I can give is when you have a cold and if your nose is stuffed up, it might not only be hard to breathe, but it also might be hard to produce your speech sounds when your nose is stuffy, and that just helps to demonstrate how dependent we are on all of these systems to be in good shape and to be working well for both communication and swallowing. The function of your larynx here, in its most primitive function, is to protect your airway. So that's one of the most important things, because you don't want anything from your own mucus or secretions to liquids or solids going into your airway. We protect our airway when there's some fumes in the air. If you're outside and there's something that doesn't, you don't like the way it smells, you might cough. That is your airway activating to protect you from getting those things into your lungs, whether it be some kind of something that you've had to drink, or even the smell of something. So like I said, we do that by coughing. Coughing is a reflex, and it is directly connected to your sensory system. If you can't sense anything in your larynx that's not supposed to be there, then you won't cough. And the cough is super important. The strength of your cough is important, and we'll talk a little bit more about that as we go on. And yeah, so you need this precise sensory awareness to be able to protect your airway. You use your larynx to lift, push, and pull. If you all were to kind of pull up on the seat of your chair or push down on the seat of your chair, you'll feel some tightness in your larynx, and that is because your vocal folds have to close for you to have the power to lift, push, and pull. And then, of course, your larynx provides the sound source, or your voice, but as all of us have experienced at some point, that's not the most important function of your larynx, even though it's called the voice box. Sometimes really breathing and airway protection are the most important functions. I want to touch on what we call sensory proprioception here for a second, because it's going to play a role in both communication and swallowing. Sensory proprioception is the perception, is your brain's ability to know what your body is doing. And we talk about sensory proprioception with Parkinson's because it is impaired in Parkinson's. A lot of the times, in a good number of cases, and maybe even it has happened with you, that somebody else has noticed the changes, noticed changes in your walking, noticed changes in your facial expression, noticed changes in the strength of your voice, perhaps before you did, and those observations from other people might have triggered your going to see your doctor and potentially a diagnosis of Parkinson's. So because sensory proprioception is impaired in Parkinson's, sometimes the person with Parkinson's might not know that their vocal volume is decreasing and people aren't hearing them well, or you might not realize that maybe it's taking you longer to eat and you haven't really realized that, or it's taking you more to chew. So sensory proprioception is important in that it's lacking, it's impaired in Parkinson's, and when we treat communication and swallowing issues with Parkinson's, we have to bring everything to a very conscious level of awareness so that you can make a change. Okay, we're going to start talking about swallowing here, and I'll give you a brief rundown of swallowing, how we evaluate swallowing, and what we can do to treat swallowing. So this just describes the phases of swallowing, and here you see that there are 4 phases of swallowing, but only 3 pictures, but that's because this pre-oral stage of swallowing is before food or liquid gets into your mouth. So you have to decide that you're going to eat or take a drink of something, and then you have to get it to your mouth. So if you are having trouble holding a utensil, and that's impairing getting your food from the plate to your mouth, we would call that a problem with the pre-oral phase of swallowing, so a problem with before the food and liquid is even in your mouth. The oral phase involves what you do with that food and liquid in your mouth, how you manage it, how you get it all into one, what we call bolus or form, to be able to swallow it. The pharyngeal phase is triggered when the food gets to the back of your mouth, food or liquid gets to the back of your mouth. You actually trigger your swallow reflex, and then your airway closes and your esophagus opens so that things can go down the right pipe. And then the esophageal phase occurs when all of this returns back to normal. Your airway opens, your esophagus closes, and the food is in your esophagus, and it's moving down toward your stomach. The pre-oral and oral phase of swallowing are voluntary. You do that because you want to. You choose to put the food in your mouth, and then you manipulate it with your tongue, your teeth, your cheeks. You manipulate it in your mouth, and you move it backwards. Once it's moved backwards and hits the back wall of your throat, then the reflex starts, and the rest of that is involuntary. If you cannot get that food from here to here, you will not trigger your swallow reflex. Okay, so the food has to move backwards, and it's done so with the movement of the tongue. And I think I say in a future slide that tongue movement backwards is not uncommonly a problem in Parkinson's. So here's just the phases of swallowing again, telling you what has to happen. Remember, the oral phase is voluntary, so that takes as much time as it takes you to chew up your food and create a bolus or form it so that you can swallow it. And then you have 1 second to trigger your swallow and get the food into your esophagus so that it doesn't go into your airway. If there is any delay or weakness or loss of pressure here, you are at increased risk for something going into your airway, and then you would cough and try to, your body would sense that, and you would work hard to get that out of your airway. And then 8 seconds from the top of your esophagus to your stomach. I want you to just think about that for a second and relate that to how fast or slow you eat, and imagine that it takes each bolus 8 seconds to get through your esophagus to your stomach. Okay, I see the comment that you cannot see my mouse. Oh, how about that? There we go. Thank you for that. I will use the pointer. So, okay, you learn something new all the time, which is awesome. Okay, so what we call a swallowing disorder, the terminology is dysphagia or dysphagia. That's the medical terminology that you will hear the medical professionals using. And depending on how sensitive dysphagia is measured, swallowing problems can occur in nearly 100% of people with Parkinson's. Now, this is not necessarily linear in that people don't always have mild problems to severe problems, always. Some people have mild issues and they stay mild through the course of Parkinson's. Some people have more severe issues right from the get-go. So it's just, as you already know, it is not the same for everybody. It's not linear. And there's things we can do. So drooling can be a sign of some swallowing problems, and I think we'll have an opportunity to talk about that a little bit as we go. So here's some signs of some swallowing problems. It's not just choking, coughing and choking, although that's a very important sign of a swallowing problem. There's other signs that you might be having trouble swallowing, and that we would like you to pay attention to so that we can help you as soon as possible. Difficulty swallowing pills, fatigue during eating. So if it's taking more work to eat, if you're getting tired eating, sometimes people then don't eat as much, and that becomes a nutrition issue. Taking longer to eat, maybe you're always the last one at the table. Nasal regurgitation, when food or liquid comes, you're trying to swallow and things are coming up and out your nose. That would certainly be something we'd want to address. Food sticking in your throat, so having trouble kind of pushing the food through and having trouble getting that to move down towards your stomach. Trouble starting the swallow. Again, I talked about how your tongue has to push the food back to trigger in the back of your mouth. So if you're having trouble manipulating the food back, then it's going to be hard to start that involuntary part of the swallow. Maybe a change in your diet. Maybe you have cut things out of your diet and you're not sure why. Maybe that sandwich is getting more difficult to eat, or maybe a vegetable like chicken noodle soup is getting more difficult to eat because it has a couple of different textures in it. Coughing or choking, of course, drooling. If you are getting recurrent pneumonia or any pulmonary infections, that potentially may be a sign of a swallowing problem. And if you've had unintended weight loss, this is not a complete list, of course, but these are some things that some people don't always think about related to swallowing. Lots of people, including sometimes your physicians, think that if you're not choking, you're not having any trouble swallowing. Well, we would like to help you prevent, from ever getting to the point where choking is an issue. So all three phases of swallowing, remember the oral, pharyngeal, and esophageal phase can be affected. The oral stage is often more involved for longer. Pill dysphagia, trouble swallowing pills, is often one of the earliest symptoms that is reported from people with Parkinson's. And tongue pumping or rocking is a very characteristic feature in Parkinson's. So, for example, if somebody is having trouble swallowing and they go in for a swallow study and this tongue pumping is observed, and there has not been any diagnosis, that individual might then be sent to the neurologist because that tongue pumping is such a characteristic finding with Parkinson's. Here are some lists of other symptoms: pre-oral phase, tremor, decreased movement, decreased accuracy of movement. So, again, trouble getting food from the plate to the mouth. Slowness, rigidity, all these things can cause trouble in the pre-oral phase. Oral phase, tongue pumping, oral residue. So maybe after you've swallowed, you realize you still have some food in between your teeth or your gums, that didn't get formed into the bolus. That can sometimes be a problem, especially if you don't know it's there. Because that can increase your risk. So let's say you don't realize that you've kept some food in there, and then you go to take a nap after you eat, and then that food moves and you're sleeping, and then you'll potentially end up coughing and choking, or wake up coughing and choking. Premature spillage means something has left your mouth before you're ready for it, before you have moved that food backwards. So if something leaks back there before you're actually ready to trigger the swallow, that can be a problem. Piecemeal deglutition, piecemeal swallowing, that means you're not potentially forming one kind of mass of food to be able to swallow, and you're just swallowing little bits of it at a time. That can be the sign of a swallowing problem. Pharyngeal phase problems, pooling at the base of your tongue and the opening to your esophagus. So we all have two sets of pockets in our throat. One is formed by your tongue base and your epiglottis, which protects your airway, and the other is formed by the opening to your esophagus. Again, if the motor movement is slow, or it doesn't have enough power or enough strength, and you don't open those pockets 100% when you're swallowing, food and liquid can stick in those pockets. You may or may not feel it, but that puts you at risk if you don't know it's there and you can't move it. Penetration and aspiration refer to food or liquid going into the airway. Penetration is above the level of the vocal folds. Aspiration is below the level of the vocal folds. Sensory deficits, again, not feeling things the way you should, slow rate of swallowing. Reduced pharyngeal constriction, that means your pharynx in the pharyngeal phase is not squeezing strong enough to get that esophagus open. Delays in opening the airway, delays in closing the airway. Nasal regurgitation, maybe your palate is not quite as strong as it used to be. Incomplete laryngeal closure, that's closure of the vocal folds to protect your lungs. Weak cough, weak tongue of base of tongue, sorry. And cricopharyngeal dysfunction. The cricopharyngeus muscle is the muscle that opens your esophagus. And if that muscle is weak and not doing its job, and you're not opening the esophagus well enough, again, all things at different levels will happen. If you won't have your airway protected enough, the food won't go into your esophagus 100%. All kinds of things that we can figure out and help you with. Esophageal phase, there can be a few things that happen there. You can have an esophageal stricture, so some narrowing in the esophagus, decreased peristalsis. The food goes down your esophagus in a double wave that gets pushed down. The food gets pushed down into your stomach. If you only have one part of that wave, that can cause problems in the esophageal phase. Spasm, reflux, these are things that can occur in the esophageal phase. So, very quick run through swallowing, and as I was reading that, I realized how potentially overwhelming all that information is. And again, I'm happy to answer your questions. So, in a quick summary, does the person with Parkinson's have symptoms of dysphagia? Highly likely. Swallowing problems are often under-recognized or under-reported by the person with Parkinson's disease, and that is because of the sensory proprioception issue. And likewise, practitioners may not identify symptoms because oftentimes, you go to your doctor, they say, "How are you?" You say, "I'm fine, thank you." And that's it, and there's no more questions asked. Swallowing problems don't always match the disease severity. But careful, targeted, structured interview with you and your family are crucially important for getting to the bottom of identifying swallowing problems and taking care of them. Okay, keeping an eye on the time, making sure we get to communication. Here's just a summary of a swallowing evaluation. There would be a clinical evaluation where you'd meet with the speech pathologist, and an instrumental evaluation, which means looking at your actual swallow function. That can be done with a modified barium swallow, that is a video x-ray, or a flexible endoscopic evaluation of swallowing. That is when a flexible endoscope is put down your nose and you're given some things to swallow and you can see the airway. And if there's any aspiration. There are strengths and benefits, strengths and weaknesses to both of these assessments. The modified barium swallow is the gold standard. There are many ways to approach swallowing treatment: maneuvers, posture, exercise, compensatory strategies, and medical management. I am not going to go through all these maneuvers. I have just put them here so that you can see and get an idea of how much is out there that we can do to help different aspects of swallow. And I just want to say here that please do not try, if you think you're having swallowing problems, don't try these things at home, because only the right maneuver and exercise is right for the individual person based on the swallowing problems, and some of the maneuvers and exercises can actually cause more problems. So please, if you think you're having swallowing problems, you need to have a swallow evaluation and make sure the maneuvers and exercises are specific for you and safe. Here's some postural techniques. Rehab is designed to improve the system. Maneuvers, compensatory strategies will help you work around some problems, but rehab and exercise is designed to improve the system. There's many exercises that can be done. Again, you're not going to do any of these unless they are specifically recommended for you. I do give you permission to do some tongue range of motion exercises. These are fine. You are not going to do any of these with food or liquid in your mouth. These are done not with eating, but you're welcome to go ahead with some tongue exercises if you would like. There are some tongue strengthening devices on the market. Again, I would highly recommend that you speak with a speech pathologist before you use any of those exercises, the tongue strengthening. Effortful pitch glide we're going to talk about in a little bit when we get more into therapy for voice problems. The nice thing about the effortful pitch glide is there is some very good evidence that performing an effortful pitch glide, meaning working hard and going to high pitch, helps not only with voice, but it also helps with swallowing. And it's such a great research discovery to know that we have an exercise that helps both communication and swallowing, because that is not always the case. LSVT, we're going to talk about in a little bit. That is the voice therapy for Parkinson's. There is plenty of evidence that has come through over the years that says LSVT also helps swallowing. There is the expiratory muscle strength trainers. These will strengthen your cough. Again, I would strongly recommend that you speak with a speech pathologist and your physician before using any of the expiratory muscle strength trainers. But these will help your cough, and there's lots of support for using these strength trainers to get a stronger cough and help prevent penetration and aspiration and help protect the airway. So these are just some of the variety of strength trainers that are out there, expiratory muscle strength trainers. Okay, you know, we usually do this, all of this in a like 4.5, 5-hour day. So I'm realizing now how fast we have to go through it to get it in an hour, and how much information there really is to share with you, but we're gonna keep at it. I'm looking at a question, is hypophonia related to a weakness in muscles or a client's misperception of the person's volume? Okay, we are going to answer that question. All right, so with communication and Parkinson's, we also know that 89% or perhaps even higher percent of people with Parkinson's are going to have some degree of difficulty with communication. And this is often considered one of the most difficult aspects of the disease. It affects employment, social activities, communicating with your family and friends, and at a very basic level, expressing your wants and needs, which is, of course, most important. Problems in communication can lead to early retirement. People start abandoning their social activities. Of course, we're in the COVID situation. We're not doing that anyways, but which is also horrible. But people stop meeting friends for coffee, maybe stop answering the phone, deciding you don't actually want to go out to dinner because the communication environment is going to be too difficult. Higher health costs for sure, social isolation, all kinds of issues with communication impairments. Some signs of communication problems: difficulty participating in conversation, frequent need for repetition, frustration, decreasing, like I said, your social activities, decreasing effectiveness in your workplace if you're still working, not answering the phone. Some things that I've heard over the years: my husband-wife partner needs a hearing aid, and what I like to say there is that may be true, but it is also highly likely that the person with Parkinson's is losing some vocal volume. So it's a team approach. Conversation happens between, or communication happens between people, so everybody has to be in a good place. I want to get what I ordered at the restaurant. I don't answer the phone anymore. These are all things that we've heard in the clinic room. So the specific disorder or name of the communication problem is hypokinetic dysarthria. This is very specific to Parkinson's. Hypo, lack of, slow, kinetic movement, dysarthria, speech impairment. So a slow moving effect on communication, which sounds familiar, right? With Parkinson's, slowness, stiffness, rigidity, and all those things affect the vocal folds. So when we talk about hypophonia, a decreased, slower phonation, we are actually talking about an impairment to the movement of the muscles to the vocal folds. And that slowness of movement, that decreased strength of the signal to the vocal folds is what causes the decreased loudness. So I hope that answers the question. So there is an actual, decreased range of movement to the vocal folds that causes the hypokinetic dysarthria, and that results in reduced loudness, a monotone. People with Parkinson's often will say, you know, my voice sounds so flat and monotone, an inability to change loudness, reduced melody of speech, and any number of other things, breathiness, hoarseness, articulation issues. Sometimes there's some stuttering, sometimes there's tremor. So slowness, stiffness, rigidity, tremor, loss of dopamine, all because your communication system is a motor system. All those things are what lead to the hypokinetic dysarthria and the decreased loudness. So what we hear, reduced loudness, mono pitch, hoarseness, maybe some imprecise articulation or mumbling. What's happening, reduced amplitude of movement, reduced vocal fold closure. What's missing, this sensory feedback and awareness. So again, lots of times the person with Parkinson's does not realize that voice is getting softer and softer and softer, and it is somebody else who is saying, I can't hear you, I need you to speak up, can you repeat that? I realized one night, probably at about 2 o'clock in the morning, that I left the evaluation slides out of the communication part of this, but the evaluation is going to take place with a speech-language pathologist. It's important that we take a look at your vocal folds, so that might also involve seeing an ear, nose, and throat physician. It's important to look at the vocal folds just so we know what's going on, for one, but also to make sure there is absolutely no other reason that you would be having voice changes or voice concerns other than the Parkinson's. So, Lee Silverman Voice Treatment, maybe some of you have heard these words, LSVT, Lee Silverman Voice Treatment. This remains the gold standard for treatment of hypokinetic dysarthria. The main premise, I think I'm going to go to a different slide right here. Let's see what it's going to explain this a little bit better. The main aspects of treatment with LSVT, the main aspect is loudness. And what we know from many, many years of research into LSVT and communication with Parkinson's is that loudness drives the system. So you may be involved in an exercise program where your physiotherapist or your exercise coach or whoever is encouraging you to use high effort. It is the same thing with LSVT. We use a high effort loudness to maximize the entire system, your brain, your lungs, your vocal folds, your articulators. Loudness drives the system. Everything gets better. All you have to think about is being louder. And then the system interacts better. LSVT is intensive therapy. The only way that we, as certified LSVT clinicians, can guarantee that you will make progress is if you do the 4 times a week for 4 weeks. Now, I certainly appreciate that that is not practical or feasible for most people, especially because MSP doesn't cover speech therapy. And that's why we're kind of out and about helping you understand the importance of at least having contact with a speech pathologist, getting some exercises, knowing what is going to be helpful for communication. But the 4 times a week for 4 weeks is very, very effective. Communication and voice improve significantly and create a new normal for communication. So loudness drives the system. It is an intense program. The brain will recalibrate to a new level of loudness. All you have to think about is being louder, which makes it, even though it's a lot of work, it makes it a fairly simple exercise, but that doesn't mean it's not work. And we go with the aspects of neuroplasticity, use it or lose it. It's important to keep those muscles moving. You know that, we all know that. Use it and improve it. We can absolutely make voice and communication and swallowing better with exercise. There are other programs. There's a program called Speak Out, which is a voice therapy program. It's based on the same premise of loudness. I think there may be a program around, maybe on Vancouver Island. I'm not sure, but it is out there, and it's showing good results. But it is also based on loudness. There are some group therapy opportunities, but I would just caution you to understand the difference between therapy and exercise. The group therapy or exercise opportunities are good and important, and they will still activate your system, but they may or may not do the same thing as an actual therapy program. Use it or lose it. Anything that you do with your voice is important. If you're singing, if you're acting, if you're talking, communicating, reading out loud, anything that gets these muscles to move is super, super important, and will help your progress. Okay, oh my gosh, I can't believe I made it on my timeline. Any questions? Any other questions? I know I blew through all of that super fast. But if you have any questions on this introduction, we're going to call this an introduction to communication and swallowing. Either raise your hand or put a question into the chat box. Okay, so is there somebody in our audience today who would like to try some of the LSVT exercises? If you would like to try, I want you to remember a couple things. We're going to turn on your audio and your video, and remember that this is being recorded. So if you're comfortable with that and you would like to try some of the exercises, I'm happy to walk somebody through them. And if not, we can try to answer some more questions, or I can go back to some information that I might have said really fast. We are certainly looking forward to figuring out how to get back to our in-person workshops, and we will keep tabs on that as public health allows, and we'll see what it's going to take for us to get back into our full-day in-person workshops. And we've got a couple people typing, so I'm just going to wait and see what the questions are. Maybe what I'll do right now is I'm going to demonstrate that effortful pitch glide to you, and I would just as another disclaimer, disclosure, whatever, please, please, please be careful if you're going to do this exercise on your own, and please be in contact with a speech language pathologist. so that you can get the right exercises for you, the best exercises, and that you know you're doing them properly. So that effortful pitch glide is an ah to high pitch, and you're just going to produce it like you're climbing up a pitch range. Ah, and you're going to take it up as high as you can go. You never want to hurt yourself. This should never feel like strain. And what you want to do is use some efforts and loudness. Ah, and just take that up. Remember, nothing should hurt. If it's difficult to do a pitch glide, if you are having trouble gliding up your pitch range, that could be a sign that those muscles are a bit weak and need some attention. And with the research in the effortful pitch glide, they also found that people who could not do an effortful pitch, who could not do a pitch glide, who could not with good effort, were at higher risk of swallowing issues. So Karen is asking, when looking for a speech pathologist, are they all well versed in these therapies, or should they have some special qualifications? Good question. Regarding any specialty, you always want to talk to the person you're being referred to and ask them if they have experience with Parkinson's. It is crucially important. Parkinson's, some issues with Parkinson's are the same and some are different than other communication and swallowing problems. But I absolutely believe that you should be working with somebody who has a fair amount of experience with Parkinson's. Regarding the LSVT, the Lee Silverman Voice Treatment, LSVT does have a certification program for speech-language pathologists, and I would recommend that if you're going to pursue LSVT, it be with an LSVT certified clinician. There's so much information and guidance through the certification program that is crucially important to be able to provide LSVT and have people be successful. Regarding the modified barium swallowing is the same. The modified barium swallow will be done in the hospital as an outpatient, and BC has what we call advanced competencies, so that speech-language pathologist needs to have the advanced competency to perform swallowing evaluations. All right, another question. My husband, who has Parkinson's, has, oops, where did that go? Sorry, just lost that. Has no appetite and his nose runs. Yeah, the nose running thing is very, very common. It kind of is with and without Parkinson's. People will often complain of nose running with eating, and it's just a kind of a charging up of the mucus secreting system. The decreased appetite is more of an issue. I would recommend that you share that with your physician and maybe try to find out why there's no appetite. Is it because there's a swallowing problem? Is it because the sense of taste has changed so much? But I would absolutely run that by make sure you talk about that with your physician. The nose running thing is not necessarily a disorder, but it is frustrating for sure. I want to talk about this ROMP questionnaire. Alana sent that to you yesterday, I believe. This is a really good way to bring up, to increase your awareness and bring up discussion with your physician. It will guide you through some awareness questions in communication, swallowing, and drooling. And this will help increase your awareness, and it will help you have a conversation with your physician. So I would encourage you to fill out that ROMP questionnaire, talk about it with your physician, see if some things come to light that you weren't quite aware of before today with communication and swallowing, and see what you need to do to get some support and help. Are there any apps you're comfortable promoting for self-management, Speech 5 or Loud and Clear? Yeah, I mean, I think going to the apps is fine. So Speech 5 is not an app though. Speech 5 is a little device, I believe, that you wear over your ear that gives masking noise and creates what we call the Lombard effect. The Lombard effect is when you speak louder in the presence of background noise. The Parkinson Society BC actually has a Speech 5 that they have loaned to us. We have not yet had great success with it, but I would encourage you maybe when we get to a point where we can have, again, face-to-face interaction, that might be something that can be trialed. There are some apps, and I think that they're fine. I would just say that it is important to at least have a baseline evaluation with a speech pathologist so that we are sure that you are not hurting yourself, that you're doing the right thing, and nothing else needs to be addressed. In the meantime, if having some voice therapy is not feasible or convenient, getting some support with going to an appropriate app is perfectly fine. I can tell you that now during COVID, most people are still, most speech paths, including myself, have switched to teletherapy. And I think teletherapy will be around for a while. It is still the safest, most efficient way to provide services, and is still the recommended way to provide services, actually, unless there is an absolute need to be face-to-face. So there are plenty of people who, speech paths, who are doing teletherapy, and honestly, people have found it much easier to not have to deal with commuting. So there's absolute benefits to teletherapy, but I would really strongly recommend that you at least have an evaluation with a speech-language pathologist before pursuing any independent practice. Yeah, so we're Risa is still sharing that the nose running activates, but there's not a lot of saliva. And the tongue pushes forward, affecting teeth. Do I think speech therapy would help with this? I think that this is all of your concerns are worth being addressed. If you have not talked to your physician about them, that is the first place I would start. And then absolutely a communication and swallowing evaluation with a qualified speech-language pathologist is going to be the right place to start there. Do we have an updated list of private clinicians? Yes, you can go to speechandhearingbc.ca, Speech and Hearing BC, and the Find a Professional page, and you can search for private practice. And people who are LSVT certified or who have, some additional clinical expertise in Parkinson's, hopefully will have identified themselves there. But yeah, Speech and Hearing BC or the College of Speech and Hearing Health Professionals both have, Speech and Hearing BC is the association. They have the Find a Professional tool on the website, and the college has a directory of all registered clinicians, and that's where you will also see who has advanced competencies for swallowing and visualizing the larynx. I am always happy to be a resource for people, so if after today you have, oh yeah, thank you, Amy, and the LSVT website, of course, has a list of LSVT certified clinicians. You're always welcome to be in touch with me. Email is the easiest way to get in touch with me these days. And I'm always happy to answer your questions and get you sorted in the right direction. The Parkinson Society, of course, has excellent research. We've worked to create some help sheets on communication, swallowing, and drooling. You've got your ROMP questionnaire now. I would, especially with some of the concerns that have been shared today, fill out the ROMP questionnaire, communicate with your physician, find a good speech language pathologist who can help with the evaluation and treatment of the communication and swallowing problems. Yeah, and LSVT Global is an excellent resource as well. 1:59. Any other questions in the last few minutes, or Amy or Lana, do you have anything you want to say here at the end of our session today?
I guess if there aren't any more questions, we can start to wrap things up. I did put also the link there for speechandhearingbc.ca. I think Catherine was asking about the clinician list. But thank you so much, Sherri. That was a very informative and helpful session on communication and swallow. And thank you all again for joining today. Please do check our website for other upcoming educational webinars. And do remember to learn more about our 30th annual Parkinson Super Walk. Again, the link for that is posted at the top of the chat box. I put it there before the webinar started. So, gather your teammates, register online, and start fundraising today. It's a really good cause, and I'd like to thank you all for being here again, and have a great weekend. Thank you.